HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
I will be speaking to Professor Jason Kovacic, and we will be looking at fibromuscular dysplasia. Dr. Kovacic, tell us about yourself.
Yeah, thanks, David. Please call me Jason. It's great to do this. So, I'm a physician scientist. I'm a practicing cardiologist. I practice at St Vincent's Hospital, Sydney, Australia. I also have an appointment at the Icahn School of Medicine at Mount Sinai and have a small lab there of just a couple of people. And in fact, I was at Mount Sinai for about 11 years and still maintain that small team there. As well as those things, I'm the Executive Director and CEO of the Victor Chang Cardiac Research Institute here in Sydney. And at the Victor Chang, I oversee what's now a national institute with about 25 labs and some 250 faculty and operations teams. So it keeps me busy, but my main research focus is vascular disease, particularly spontaneous coronary artery dissection and fibromuscular dysplasia.
Now, once again, Jason, what is fibromuscular dysplasia?
So, David, fibromuscular dysplasia, or let's just call it FMD for short. First, it needs to be distinguished between fibromyalgia and uterine fibroids. So my patients often get the three confused. This is very different from fibromyalgia, obviously completely different to uterine fibroids. So fibromuscular dysplasia is a disease that was first described about 85 years ago. It's a disease of collagen matrix that affects the arteries of the body, and it probably actually has features that extend beyond the artery walls, and there may be some soft connective tissue features in other parts of the body. But it's a disease predominantly of the artery walls where there are several key features of the arteries. The hallmark feature in the most common form of FMD is what's called string of beads. And I hope your listeners have seen a string of beads or know what I'm talking about, but it's this classic appearance of usually the renal or the carotid vertebral arteries of these alternating bands of stricture and mild dilation. So a string of beads, a necklace of pearls, one of my patients calls it the artery with bubbles. All of those things, I think, hopefully convey that alternating stricture and mild dilation. And that string of beads of fibromuscular dysplasia is the hallmark. And in 2024, you need to have a string of beads to have the diagnosis of FMD made. There are other features, though, of the disease, and that includes arterial dissection, arterial aneurysm, tortuosity, arterial redundancy, so there can be actually loops of arteries and things like that, and ectasia. So all of these features are part of it, but you need that string of beads to have made the diagnosis.
So it's a collagen disorder. What causes it, Jason, and is it hereditary?
Yeah, it's a great question. Thanks, David. So like we're saying for SCAD and like for many diseases that we deal with, FMD arises due to a combination of environmental and genetic factors. So we've done a lot of work. In fact, it's been my life's work, the genetics of fibromuscular dysplasia. And just a side story, I got into this because when I graduated as a cardiologist, I did some research. I did a postdoctoral fellowship and a PhD. But as I was wrapping up all of that stuff in about 2009, I thought to myself, well, there's this disease, FMD, and in 2009, 2010, it was absolutely the most common cardiovascular disease at that time, about which we knew nothing whatsoever back at that time. So just 15 years ago, we didn't know its cause, we didn't know its genetics, there were no genes linked to it, we really knew nothing. So I made it my career to try and understand this disease, and I've been really thrilled that over the last 15 years, we've actually made quite a bit of progress. So we now have identified 5 or 6 genes that are linked to FMD. And as I mentioned in the SCAD podcast, where the first gene that we linked to both SCAD and FMD was this gene factor 1. Factor 1 and the other genes we've now linked to FMD appear to perturb collagen and matrix regulation. And that leads to this particularly dissection and aneurysm, these alternating string of beads that we see in the arteries. But FMD is also partly an environmental condition. So I think the best example I could give of that is that FMD is more common in the right renal artery than the left renal artery. Now, why is that? That's because the right kidney sits immediately up under the liver. And it's actually a proven fact that the right kidney moves up and down with respiration an inch or two more than the left kidney. The left kidney actually sits under the spleen and under some bowel, and that spleen and bowel soaks up the diaphragmatic movement. So the left kidney doesn't actually go up and down as much as the right. So that constant moving up and down of the right kidney and that movement of the kidney on the right renal artery is thought to account for the higher prevalence of FMD in the right renal artery than the left renal artery. And likewise, the carotid and vertebral arteries, which is another common site we see FMD, these are arteries that are constantly moving as we twist our neck around all the time, every day. So both environmental and genetic factors cause FMD.
How fascinating. Is it hereditary?
Yes, so the genetics of FMD are complex, as are the genetics of SCAD, but they are hereditary, but probably more in the sense of the hereditary passage of atherosclerosis or other what are called common complex diseases from one generation to the next. So most of the common diseases we deal with in practice they're what are called common complex diseases. And these are diseases where there are hundreds or more genes that all have a weak effect on causing the disease. But if you inherit many of them, that combines to increase your risk of these diseases. So that's the case for atherosclerosis. It's the case for most hypertension. It's the case for most diabetes, that they have these common complex genetics and inheritance patterns. And SCAD and FMD have that pattern of inheritance. So we do actually see families where the mother, I've even got 3-generation families with the grandmother, mother, and daughter all having FMD. And as we've said with SCAD, both SCAD and FMD are diseases that overwhelmingly affect women. About 90% of cases of FMD arise in women.
How common really is it? Because you said 90% of FMD occurs in women, but how common is FMD?
Yeah. So this is the question I love the most, David. I really love this one. So when I started studying FMD around 2009, 2010, it was thought to be a rare disease. And the prevalence at that stage was thought to be about 1 in 2,000 to 1 in 3,000. So what we now know is that we were wrong, completely wrong.
Wow.
The prevalence of symptomatic FMD or FMD with complications like arterial aneurysm dissection and so on, that's about 1 in 2,000 or 1 in 3,000 of the general population.
Okay.
But the actual prevalence of FMD is around 3 to 4% in the adult population.
Okay.
So it is way more common than we appreciate. And of course, therefore, most people with FMD are blissfully ignorant of it, and they may never know about it in their lifetime, and they will ultimately die of something completely unrelated. But we know now from very carefully done studies, for example, in kidney transplantation, where they carefully screen for FMD before offering a kidney up for transplant. We know that FMD arises in 3 to 4% of the adult population. And that may be more even in its sex distribution than the symptomatic FMD, which is predominantly women. And that actually fits, if I can for a moment, David, that actually fits with the genetics, because as I was saying, the genetics of FMD and atherosclerosis and most hypertension, most diabetes, these are called common complex diseases because they are quite common. So by the nature of the genetics, when we started understanding the genetics, we thought, hang on, this disease should be way more common than we're seeing it. And then sure enough, at the same time, we started seeing these studies coming out from kidney transplantation and also the renal artery stenting studies. You know, the renal artery stenting, there's been a lot of studies on that. When they carefully went back and looked at the angiograms of the people getting stents for renal artery stenosis, they found that about 5% of them actually had FMD, not atherosclerosis. So yeah, it's all the data is starting to make sense.
This is actually quite interesting as a GP because now you're actually telling me that, a significant number of my patients who are extremely well and possibly very young with no symptoms at all might well have FMD.
Well, they probably do have FMD. Is actually the reality. So yeah, about 1 in 20 are going to have
That's
FMD. And
incredible thought.
a great question comes, what do we need to do about that?
Yes.
Well, I'm not doing much about it, to be honest. I think if they've not had symptomatic FMD and they don't have a family history of symptomatic FMD, then, why do we actually need to go bothering them? I don't think, in that cohort, there's no data to suggest they're at increased risk of anything. So I tend not to I've not started screening people just from the general community in the absence of other features such as a family history or prior events like a SCAD or an arterial dissection or something like that. But it is a lot more common than we've appreciated.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
What is the current best practice treatment and management of someone that has been found to have FMD? And you also mentioned that, part of the problem is that the kidney just bobs up and down and there's stresses on the artery and also the neck. How does lifestyle impact on this? So there's 3 questions: treatment, management, and lifestyle.
Yep. So let me start with management if I can, because I think the first step is to properly define the extent of the disease.
Okay.
So traditionally, we've done a lot of duplex ultrasound to diagnose FMD. And what's become very, very clear is that duplex ultrasound is extremely operator dependent and is very also dependent on how often the FMD is actually looked for and seen in the different centers that are doing duplex ultrasound. And this is not to be critical of our colleagues in radiology and ultrasound, but unless they're at a highly experienced vascular duplex ultrasound facility, they probably don't have the experience to be good enough to pick up FMD in most people. So for that reason, and also because ultrasound can't get everywhere. It can't, for example, get into the intracerebral circulation. It can't get to all vascular beds. For those reasons, we advocate for head to pelvis, either magnetic resonance angiography or CT angiography of all people where we're considering a diagnosis of FMD. Head to pelvis, including the intracerebral vessels. Because, as we've said, aneurysm is a feature of FMD. And if someone's got an intracerebral aneurysm, we want to know about that because they can rupture, as your listeners know, but they can also be treated and they can be clipped, coiled, surgically excised. There's treatment options. So if someone's got an intracerebral aneurysm, that needs to be dealt with and managed. Or if they've got a large visceral aneurysm, for example, hepatic artery, splenic artery, renal artery, that needs to be managed. So step 1 in management is defining the burden, the extent of FMD, and that's with head to pelvis, CT angiography, or magnetic resonance angiography. And I'll just share my personal practice. As you all know, there's a lot of bony artifact with CT, but there's less bony artifact with MRA. So I tend to do MRI of the head and neck, and CT, CTA of the chest, abdomen, and pelvis. And I do them as 2 separate scans. Some places prefer to do CTA of the head and neck. That's a little bit more radiation that we can perhaps spare with MRA. And if we're just screening, I think MRA is often adequate. So that's my practice, but either or is acceptable. Then for management, if there's something found like an aneurysm or a dissection, and we occasionally turn up chronic old dissections as well, they need to be managed on their merits. And obviously that's generally a specialist referral for that. Even for me, I'm a cardiologist, vascular physician. If I find an intracerebral aneurysm, they're off to see a neurosurgeon to have that properly managed. And it may be watched if it's just a small aneurysm, or it may be clipped, coiled, or surgically fixed if it's a larger aneurysm. The next thing is in terms of general, assuming they don't have an aneurysm or something that needs any therapy, The next step then is to define the severity of stenosis, because CT and MRA will give an anatomical picture of FMD. It won't tell us flow or gradient or velocity. And that's where the duplex ultrasound scanning comes in. So if we've found on CT or MRA, particularly, for example, what looks like moderate to severe renal FMD, then I'll do the duplex to define the severity of stenosis and define the flow velocities. So that needs to be done in a very specialized vascular imaging service, ultrasound service that's got specific experience at doing this. Just a general referral to a general radiology service, I don't think is adequate. It needs to be sent. And if your listeners are unsure, any vascular surgeon or vascular physician will know and will be connected to the right services that can deliver that really high level of scanning. So once we've defined the burden of disease and figured out these things, if someone's obviously got a lesion that needs to be fixed, whether that's a tight renal artery stenosis, an aneurysm or other thing, that needs specialist referral. And I would just add quickly that for significant renal artery stenosis from FMD, we don't stent. It can usually be managed with just angioplasty alone, and we usually get excellent and durable results from angioplasty alone. Most people with FMD, we put them on aspirin. If they don't have an aneurysm, I don't start the aspirin initially. I'll make sure they don't have an aneurysm first. But if we've ruled that out, then we put most people on aspirin, a baby aspirin a day. And that's because while there are no clinical trial data, people with FMD can definitely form blood clots in the recesses of the string of beads in the arteries. And those little blood clots can flick off and embolize, cause small strokes, cause renal infarctions, splenic infarctions. And I've got several patients with each of those in my practice where they had little emboli before they were commenced on aspirin. Strict blood pressure control is a cornerstone of management, because blood pressure control is one of the things we do to avoid arterial dissection. So blood hypertension in FMD arises in about 2/3 of people with FMD, and that's independent of renal artery stenosis. It's only a small proportion of FMD patients need renal artery angioplasty because of significant renal artery stenosis. But even in the absence of renal artery stenosis, about 50% to 2/3 have hypertension. And that's probably due to microvascular changes in the kidney that are driven by these same genes that are causing FMD. So for those patients, we tend to prefer ARBs because there is data from Marfan syndrome and other arteriopathies to show that ARBs tend to have extravascular protective effects. So I tend to start candesartan 4 milligrams, but any of the ARBs are very reasonable to use for hypertension control. And I do, with FMD, with SCAD, with any of these arteriopathy patients, be particularly aggressive with blood pressure control, because it's one of the key things we can do to reduce the risk of arterial dissection. So I'll have them in the clinic more often than normal. I will not tolerate 128/82. You might you might turn a blind eye to that occasionally in a younger patient. I won't turn a blind eye to that in an FMD patient. And then finally, David, for management, the same things that we said about SCAD also apply to FMD patients. So there's a black box warning against fluoroquinolones, so they should not be used because they're associated with arterial dissection events. So that's ciprofloxacin and levofloxacin and all that class of medications. The chiropractor is out because of neck manipulations and the risk of arterial dissection. Extreme yoga with extreme yoga positions is out. Gentle yoga is fine, but not particularly when the neck is being put on significant stretch or torsion. Activities at risk of significant acceleration, deceleration, like bungee jumping, parachuting, motocross, car racing, that's all out. But as always, light to moderate aerobic activity is in and is strongly encouraged. So that's my management, David.
Jason, in your talk on SCAD, beta blockers played a very important role. I hear that you're more favoring the ARBs in this case for the management of the hypertension. Does beta blocker have a role?
That's a great question. So I often even think about that myself when I'm seeing an FMD patient that hasn't had SCAD. What should I be using beta blockers? If they're FMD that's had an arterial dissection event, I will use beta blockers. there's not a lot of data to support beta blocker use, for example, for a mesenteric artery dissection or a carotid or a vertebral artery dissection. But I think what you're saying makes some sense. And I do extend my beta blocker use to those patients. As I said before in the SCAD podcast, if they get migraines, and migraines are associated with FMD and SCAD, about a third of patients with FMD will get migraines, then propranolol can be really helpful because that's a second-line agent for prevention of migraine. And for whatever reason, they tend to actually respond really well to propranolol if they have FMD and migraine. So, yeah, I think there is a role, but it's more limited to dissection events. And I would say that if FMD, so 50% of SCAD patients have got FMD.
Okay.
If you've got FMD but never had SCAD, the likelihood of having SCAD in their lifetime is only about 1 or 2%.
Oh, okay.
The likelihood of having any arterial dissection event is 20 to 30%. So those are, I think, helpful numbers to bear in mind.
Incredibly helpful. It's just cleared my mind up. Now, are there specific things that GPs need to look out for when a patient is being treated for FMD? And what are some of the clinical symptoms and signs a patient may present with that can be FMD?
Yeah, so that's a wonderful question. So the common clinical manifestations of FMD are migraine headaches, a whooshing sound in the ears. So this is called, it's actually called pulsatile tinnitus is the name. So as you know, tinnitus is just a ringing sound. Pulsatile tinnitus is where they hear whoosh, 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 whoosh with each heartbeat. And often, you know, when they're lying in bed, it's a quiet night and they hear this whoosh, whoosh, whoosh. And the whoosh roughly correlates to the severity of carotid arterial turbulence that's arising from FMD. So that's common. And hypertension is the other one that's fairly common. So absolutely, as your listeners know, anyone who's got unexplained hypertension, either whether it's at an early age or it's particularly aggressive, that warrants investigation with arterial duplex studies at a minimum of the renal arteries. If not, as we've said before, CT or MRA, because they're just so much more accurate and sensitive for the diagnosis. Obviously, you need to check creatinine and renal function, though, before you give contrast in a CTA or MRA. So I always in a new patient will check their bloods to make sure their creatinine is stable before we can give them contrast. Those are the main manifestations. There are many other possible manifestations of FMD that go right up to sudden death. And sudden death can arise from catastrophic stroke, catastrophic SCAD, mesenteric arterial dissection with gut ischemia. So those are the thankfully very rare presentations of FMD, but unfortunately they can arise. And there are some others in the middle, such as like limb claudication, quite rare, gut mesenteric angina from, for example, a celiac artery stenosis, so postprandial abdominal pain. Those are much less common presentations of FMD.
One thing I'll never forget to ask is this pulsatile tinnitus. I mean, honestly, I don't think I've ever asked anyone if they've got it.
Yeah, no, and it's in an FMD patient, it's quite common. And there's actually a website, I think it's, here we go, whooshes.com, because it gives a whooshing sound, whooshes, WHOOSHERS.com. There's an online website, a support group for people with pulsatile tinnitus, because it drives them nuts. You can imagine, it really drives people crazy, this constant whooshing sound.
Let's just say that I have a young woman who has now been diagnosed with FMD. She's got the string of beads, and she's planning to have a child. I know there's a smaller correlation between FMD and SCAD. Would there be any specific advice that we might give this woman?
Yeah, thanks, David. That's an important question. So for pregnancy in a patient with FMD, if they've not had an arterial dissection event, I'm slightly more relaxed and slightly less obsessive about their management. Again, it's critical in these patients to define the full extent of FMD. So I would make sure we've done head-to-pelvis MRA or CTA, then we make sure they don't have an aneurysm or something like that, particularly in their head that might have gone missed, because you don't want someone going into labor with an intracerebral aneurysm. Assuming that's clear, I will counsel them very carefully and explain that blood pressure management is really key, attending the clinic visits, and potentially having a high-risk OBGYN team around them is important. But in just an FMD that hasn't had a dissection event, I think that's a reasonable proposition to have pregnancy. And indeed, as we've said, FMD is so common, it affects about 1 in 20 people. Probably there's a lot of women with FMD that are giving birth and never knowing about it. If they've had a dissection event in the past, that's a different situation altogether. And I'll be much more cautious in those people. If they've had a peripartum dissection event, I really don't sanction pregnancy at all. I think that's just too high risk. If they've had a dissection that's removed from the time of pregnancy, it's very much as I explained in the SCAD podcast, I will sanction a pregnancy, but it's only under a fairly strict set of terms that they need to get my approval. So that involves negative genetic testing, being at least a year out from their dissection event, and things being quite stable. And I would just add one other thing. There is some data, it's not human data, it's animal data, that links breastfeeding to arterial dissection events. And it's possibly due to the oxytocin that's released at the time of breastfeeding that's associated with arterial dissection events. So we always have very careful discussions about breastfeeding. There will never be human data on this. I don't think we're ever going to have a randomized controlled trial. It would need tens of thousands of people. But we have a very careful discussion about breastfeeding because I fully appreciate the importance of breastfeeding and the bonding that goes on there. And, you know, there's so many positives about that. But particularly in a woman that's had an arterial dissection during breastfeeding, we have very, very careful conversations about managing that.
Most important information. I suspect for this group of women, induction is probably not on as well.
For women that have had prior dissections, we occasionally will do cesarean sections, and I leave that to the discretion of the obstetrician. Some of my obstetrician colleagues actually prefer a cesarean delivery and don't allow labor. We are getting a little more permissive. And for women that, you know, perhaps their dissection event was several years ago, it was well removed from the time of childbirth, they've been completely stable, it's been an uneventful pregnancy, they will allow them to labor. But there, as you can imagine, there is a lower threshold to convert to cesarean if things aren't going according to plan.
Well, thank you for that. Now, again, another incredibly interesting and fascinating topic. Jason, how about some key messages for our GP listeners?
Yeah, I mean, first, thank you for listening. I think it's great that people are interested in these topics. I would start by saying FMD, it's really not as mysterious as people think. It's just a disease where we're rapidly gaining knowledge. It's far more common than we appreciate, probably present in 3 to 4% of the adult population. But thankfully, symptomatic FMD is only present in about 1 in 2,000 of the general population. Common features can include whooshing or pulsatile tinnitus, migraine headaches, and hypertension. I think it's important to screen for FMD when someone presents with early onset hypertension, particularly in a female, or in hypertension that's just progressive and difficult to control. The management of FMD first starts with properly defining the extent of the disease, and that involves CTA or MRA of the head to pelvis, including the intracerebral vessels. Any complicated findings like aneurysm, dissection, etc., should be a specialist referral. But assuming none of those features are present, the standard management is a baby aspirin a day, 100 milligrams a day, and very careful control of blood pressures, usually with ARBs, occasionally with other agents like beta blockers or others. There are certain things to avoid. We've said these before, but just to reiterate, fluoroquinolone antibiotics, the chiropractor and particularly neck manipulations, aggressive yoga positioning, sudden acceleration, deceleration activities like bungee jumping and motocross racing. but light to moderate aerobic activity is always encouraged.
Thank you very much for your time in teaching, Jason.
Again, I'm very happy to have done this podcast, David, and I thank you for the opportunity.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.